devices for cardiogenic shock, structural heart interventions, and of course, robotic assisted PCI. Now this evening, he's going to share with us robotic PCI in Hong Kong. So I would like to welcome Dr. Michael Lee. Michael, please.
Thank you very much for your very kind introduction, CK. I'll welcome you all to this first robotic PCI webinar in Hong Kong. I know most of you are traditional, what we call, or manual PCR operators. But in these few years, robotic PCI has gained much popularity in the US, in Europe. Now it's coming to the Asian countries. So I'll just talk in the next 15, 20 minutes or so on how we have been engaged in this technology and bring it to Hong Kong. So as you all are traditional or manual PCR operators, we know we have to put on our lead, work in the cath lab, exposed to radiation when we do PCI procedures. And the monitor is always a bit far from us. We have to look very attentively at the monitor during our procedures. And with this robotic assisted technology, when we do PCI, what we have to do is we just sit in the console, which is shielded from radiation without putting on our lead, and actually do away with a lot of the orthopedic problems, back pain, and also reduced radiation exposure. What's more, actually with this robotic assisted technology, we can actually do a very accurate assessment of, first of all, the anatomy, because we are facing with a very nice monitor, very big TV monitor in front of us. And then we can actually do very accurate, precise millimeter to millimeter measurement and put our device or stand a balloon in a very accurate position and without movement. This is something we have to adjust to when we engaged in the robotic technology. So what we have in our lab is, first of all, this bedside unit, what we call the robotic arm. Actually, it is through this robotic arm that we plug in our guiding catheter, guide wire, as well as the other devices such as the balloons, the stents. So we have to have a fellow or a cardiologist here, together with a nurse maybe, working by the side of the patient to help us to put the device in. And what the cardiologist would do is we sit back in the console, what we call the interventional cockpit. Some of the centers put this cockpit inside the cath lab, but for us, we actually move it out to our control room. With these three joysticks, we can control, first of all, our guiding catheter, our guide wire, and all the other devices such as balloons, stents, even sometimes the IVUS catheter. And then we actually move this to move our devices in and out of the patient. And then on this monitor, we actually can also control the very precise millimeter to millimeter movement of both the guide wire and the balloons or stents. This is the basic setup for the robotic PCI. So our journey actually started way before 2018. We got interested in this technology, have been a few years, and then we actually also test run the device during one of the EuroPCR meetings. The same device that you are going to be able to participate in the test drive tomorrow. I think they have arranged some test drive model for you to test on tomorrow. We test it. And then in December 2018, actually, we went all the way to New York to observe cases in Columbia University together with our mentor, Dr. Manish Parikh. We actually attend his didactic lectures and then see him doing cases in his own lab. In his lab, what he has done is he put this cockpit inside the cath lab. He is still wearing a lab, as you can see, because he's helping out with the setup of this robotic arm. And then he will return to the chair and sit there. Sometimes he will take off his lab. This is how we have been engaged in observing the first robotic PCI live case there. And then the next day, we actually attended the animal lab nearby New York. There's a Center for Innovation in which we can actually perform our first robotic PCI procedure in a pig model. In that very first time, we actually boldly performed a Kulok stenting inside a pig's heart with actually kissing balloons. It has been very successful. It's been very good experience for us. And then some of us actually also attend another animal lab session in Singapore in 2019. Try to learn more from other operators and then get some hands-on experience in an animal model. We actually, during one of our TCT meeting, just before the TCT, we actually went to visit Bill Lombardi in University of Washington Medical Center and see him do some of his more challenging CTO cases. Sort of a hybrid approach. He would cross the lesion with the manual guide wire first, and then connect it to a robotic model, robotic arm, and then to finish the whole procedure afterwards. This is how we get to know some of the more complicated robotic PCI cases. We also went to visit Paul On in Tung Tok Seng Hospital in Singapore and see his setup. His setup is very similar to us. His cockpit or the console is actually outside the cath lab in the control room, where he communicates through this microphone and watch them to set up the guide wire and balloons, and then performing PCI procedures outside. So that's how we get to know this technology, and then we bring it back and discuss in the hospital authority, going through proper technology assessment and then get funding for us to start our procedure. We started our first procedure a little delayed because of the COVID pandemic. With no option, we have to do it through a sort of remote training and virtual proctoring. This is Joe, our proctor, and this is how we have started our first few cases, and also how to set up the system during our sort of pre-procedure training. So this is our setup. As I mentioned, we have this robotic arm inside our lab, and our console is actually at the corner of our control room outside the lab, outside the cath lab. So while some of us are actually connecting the devices to the robotic arm, I will be, the chief operator will be sitting comfortably in a chair and then control the whole procedure, usually with a cup of coffee beside me. So this is how our first robotic PCI procedure. We haven't showed this to Dr. Grantham because I know he will disagree. This was our first case because we don't really have simple cases. I would advise you to start with simple cases if you can. Our first case is sort of very diffusely diseased RCA, a lot of stenosis, several. So we end up using 2 guide wires, 3 balloons, and 4 stents to achieve this, I would say, a very, very reasonable result at the end of the procedure. So it's not a really difficult procedure, but it takes some time, but we can actually achieve a very satisfactory result. And afterwards, we continue our journey. So you can see this is our whole setup. This is our control room. Behind the glass is the cath lab, and the robotic arm is here. And the main operator will be sitting outside the cath lab in the chair. Actually, we have a remote control of the X-ray pedal as well below our feet. So it's sort of a very nicely thought environment so that we can actually do the case without really looking at our patient or even our assistants. So we continue our journey and we practice and then we refine our skills and then we embark on more complex cases. So this is one of the few bifurcation cases that we did. You can see we make use of the accessory port as well. 2 balloons doing a kissing balloon angioplasty at the end of the stenting procedure. Just to show you a few of our cases very quickly. I know Alan is going to show you more detail of our few cases later on. This is our case using the left snub box puncture technique. We sometimes use the left radial artery or the snub box as a puncture, mainly because we thought left side puncture would be actually more comfortable for our patients. And with the availability of this robotic technology, we can actually make use of the left side of the left arm of the patient so that we don't have to lean all the way forward to do our procedure as in our manual procedures. So this was actually a robotic SABO procedure for precise osteo-LAD stenting that I have presented during our last Robo Summit meeting. So very precise placement of the osteo-LAD stent, and then we can achieve a very nice result. And then this is what I mentioned. Actually, even with very calcified lesions, we make use of the IVL balloon. I hope you can see this IVL balloon cracking the calcium. We actually also performed OCT interrogation of the vessel pre and after the procedure. So you can see this very thick calcium after IVL, adequate cracking of the calcium, and then this is our stenting procedure. For this OCT procedure, we have to do it manually because the system is not compatible with OCT machine right now. So we do the OCT manually and then switch back to robotic PCI for both the IVL balloon as well as the stenting procedure. So this is a case earlier this year because by that time we have a new software available for us to do not only the ROR, not only the rotate on retract, but also the wiggle, the spin, because as you can see later on, during Alan's presentation, actually this is the wiggle of the guide wire to just get across some of the more tortuous vessels, and then some of the more challenging, like this distal RCA subtotal occlusion. We make use of the spin function of the guide wire, and then help us to finish this robotic PCI stenting procedure. So we have been doing quite a number of quite complex cases, I would say. We've done cases for true bifurcation lesions with DK crush and then kissing balloon, and also protecting the side branch with the modified gel balloon technique. Sometimes we encounter calcified lesions. We will make use of the IFAs and also some scoring balloons. And then we've actually made use of the SABO technique as well for the right side for very precise osteo-RCA stenting, robotic shortwave IVL with OCT guidance, as well as a hybrid procedure. Some of the CTO procedures, we wire it manually and then switch it back to robotic PCI to finish the whole procedure. And currently we are running our own local hospital robot registry. This is a sort of a 50 patient registry. We just want to test out the feasibility and then the radiation dose, the time needed for us to finish the procedure. So this is our own local registry. And then very soon we'll start our robotic PCI fellowship training program, which actually we started, actually we started with our first fellow with the didactic lectures already, and then he's going to observe us doing cases. And then actually he will also be have the chance to connect the robotic arm to the guide wire by the bedside. And then we will observe him doing several cases before we certify him to be a truly independent robotic PCI operator. So I think the journey won't stop here because we are actually doing very regular robotic PCI procedures now. But what is more important for us is we are looking at the future more advanced robotic capabilities. Dr. Patel from India has already shown, this was actually 2 years ago in India. He was actually doing 5 PCI procedures in a temple 20 miles away from his hospital, from his cath lab, and very successfully performed all the 5 procedures with this remote technology. So to summarize, what we have gone through is we actually have received this case observations overseas, and then we actually bring it back to Hong Kong, gain hospital authority approval, and then let's go through proper technology assessment. And then we actually will start as well together with the Hong Kong West some of the pilot program. And then we are actually committed to train interested cardiologists on this robotic technology, try to roll out to other hospitals. And then we are very looking very closely to the possibility of remote robotic PCI with 5G capability. And hopefully, not only we will be doing our own robot registry, we are ready to collaborate with other centers in India, Singapore, Malaysia, Thailand, Philippines, so as we can actually collaborate to do our own robotic PCI registry or even live demonstration conferences in the very near future. Thank you very much for your attention.
Wow, thank you, Michael. This is really amazing. I'm really surprised that we're not just treating simple type A or B lesion. Those are very, very complex lesions already. It's really a pleasure to know about this.
So should we leave the question time like after Dr. Grantham's talk?
Yes, exactly. So that maybe Michael.
Yes, let me introduce
please.
Dr. Aaron Grantham. Aaron actually attended medical school at the University of Kansas. He completed his internship as well as residency in internal medicine at the University of Kansas, and then completed his cardiology in interventional cardiology training at Mayo Clinic. His primary interest, all of us will know, are in the diagnosis and treatment of chronic total occlusion as well as structural heart disease. He's been very involved in this robotic program. He's one of the few pioneers in this technology. And he's currently the cardiovascular consultant at St. Luke's Cardiovascular Center in Kansas City. But he is also the chief medical officer of the Siemens Corindus organization. So he's actually the best person to talk to us on how to build and drive a robotic program in the hospital. So let us welcome Dr. Grantham.
Thank you very much, Dr. Lee. I appreciate your kind introduction and the invitation to participate in this exciting webinar. I hope you have a great turnout and a successful meeting. I'm sorry that I have to leave shortly after my presentation for another commitment, but I'll do my best to answer questions when we're done. I was asked to speak about building a robotics practice, how to drive a robotics practice, because it does take some work to develop and to maintain a successful robotics practice. You know, the robot, I consider it to be an early device iteration. It is not the way, this current robot will not look the same in 10 years. It's going to be vastly different. And I think all of us are going to benefit from the developments and the collaborations now that are available through Siemens with their advanced imaging and their artificial intelligence. They have some, the second most patents in artificial intelligence to Google. So I think we're set up for the future here. I will say, just for a point of clarification, I am now just a consultant for Corindus, no longer the chief medical officer. And that's important because it allows me to be more free about my speaking and brings less scrutiny from the CME regulators. So I am a consultant for Siemens Healthineers now, no longer chief medical officer. So I'm going to do about like Dr. Lee did, just tell you about my robotic experience and the development of our practice, and try to highlight some key learnings along the way, and hopefully set up new operators for successful building of a CTO practice. I'm our institution CTO chip operator. Bill Lombardi is one of my best friends in the world. I just got off his boat in Alaska and brought home 57 pounds of halibut. So we have a good time together doing chronic total occlusion, angioplasty, and teaching people the hybrid approach. Briefly, in 2004, I started training in CTO PCI. I graduated from Mayo Clinic in 2000. I came to Kansas City. I joined the group here where they were aggressive about CTO interventions, and I learned a lot more about it from the Japanese masters and faculty. Became faculty at the New York CTO Summit. Again, met Bill and Craig, and we developed the hybrid algorithm, published it, and I think it's become a very popular approach, and it's been iterated according to regional needs in a multitude of ways. In 2013, I had a lumbar discectomy for a herniated disc, and that was life-changing, and then had 2 episodes of cervical spondylitis. In 2015, I ran a large registry called OpenCTO. We've now published 23 papers out of that, and I do about 150 CTOs a year, which may not sound like much to Asian Pacific operators, but in the US, when the average operator does 44 PCIs a year, 150 CTOs is pretty busy work. In 2016, Mark Toland, who was the CEO at Corindus at the time, came to me about robotics. And frankly, initially, I wasn't very interested. So I started thinking about my back and my career and my longevity and about how it was going to feel to be retired with all kinds of back problems and neck problems, and decided to get more involved and became CMO after we acquired a robot from Corindus in 2017. And to date, I've done a little over 300 robotically assisted PCIs. As Dr. Lee indicated, I started out as one of the very early users with the GRX system with a fairly conservative approach, and that was trying to select simple cases. And as Dr. Lee said, you know, I've been all around the world teaching CTO PCI, and I've never met an interventional cardiologist who does simple PCI. I don't know who those people are, but these are hard cases to come by. That picture in the right corner on the left, you know, I don't see those very often either, but we took some time to find about 10 or 15 cases and do these very systematically. The point of the picture in the middle is to show me attaching the robot, and I wanted to make the point that I think one of the key things to developing a program is that you have to be the master of this device. You need to understand the inner workings of the device, the outer workings of the device. You won't understand the software, but you need to understand how to drape it, how to attach it, and then how to troubleshoot some of the problems that you might face, and be the expert. Do not defer to a representative from the company or to a super user tech or nurse. Make sure you know everything about the robot, and I think that'll help to drive your program to success. Initially, we did like Manish does, and I would sit in my lead, drape the console, and stay scrubbed in because I was nervous that I'd have to unscrub and do something very quickly. And over time, it was clear that that wasn't going to be the case. So the second key to building and driving a successful program is to develop a super user team. And this is the early super user team from 2017. 3 of our technicians, Tina, Buffy, and Rachel. Rachel was the lead tech. Rachel was incredibly interested in new things in the cath lab. She was just one of those young and enthusiastic people who was never satisfied with the status quo. And when I talked to her about robotics, she went to the company website, she printed the user manual, and she came the next day and told me she had highlighted 28 things that she wanted to discuss with me about robotic PCI. And we went over those. It took about 2 days to get through all of her questions and comments and concerns about robotics. But that's the type of person you want by your side when you're developing a robotics program. And she brought along more young and enthusiastic, very intelligent and very talented people like Buffy, Tina, and Megan. And one of my colleagues, John Saxon, joined me as a co-user, and 3 other of our physicians have learned how to use robotics and would describe them as coming along, but not incredibly active in robotic PCI. So develop a team, encourage a team. And quite frankly, Rachel was one of those people who's so talented that now she's gone into industry. They picked up on her abilities very early. She went to work for Penumbra, but she had opportunities all over the place because she was that type of person. So we've replaced her with actually 2 others now that are coming along as well. So after about 20 cases, we became very comfortable with the robot. The picture on the left is a little sarcastic, but it really had gotten to the point where the cases were hard to find that were simple. So we decided we have to find a way to use the robot, not just find ways to not use the robot. And that's a mindset that's very important. You need to develop a robotics first mindset so that your team and you have a daily experience. If you're having a monthly experience, nothing ever goes well when you do it monthly. It doesn't matter if you're playing golf or you're doing robotic PCI. If you only do it monthly, you'll never be a scratch golfer. So you gotta practice, practice, practice. And in order to do that, you have to find ways to use the robot. And because of the fact that I'm this chips operator, I get a lot of complex cases as well, just like everybody. This is one example of something it's an old case presentation, but it's something that is what Dr. Lee referred to as the hybrid approach to robotic PCI, a little bit of manual, a little bit of robotics. It's an 84-year-old with chest pain. He had a non-STEMI and was referred for coronary angiography and intervention. This was his left main and ostial LCX lesion. It was heavily calcified. He was codominant, and so it was a very important vessel for him and severely calcified. So our plan was, at the time, this was pre-shockwave in the United States, was to do rotational atherectomy, IVUS, and then a single stent crossover technique into the circumflex. So because we were going to use rotational atherectomy, which is an over-the-wire device, which is not compatible with robotics, we decided to do this like a CTO procedure, is to use a Corsair Pro XS microcatheter, Xeon Blue wire, which at the time was my workhorse, and now it's a Monamo, and easily exchange. It allows you to easily exchange for different wires so that you can cross the lesion, manually wire the lesion, take the Corsair across the lesion, exchange for the rotofloppy wire, and then we did rotational atherectomy. So that's just a quick video of our fellow Justin Sheehy and Rachel doing the rotational atherectomy. I'm back in the cockpit observing. And again, Rachel's one of the super users, and they were able to do the manual rotablator to prep the lesion. And then after that was done, we took the rotofloppy out through the Corsair and exchanged that for a workhorse wire, and then began our robotically assisted portion of the procedure. It's important before these procedures, as you get started, that everybody in the cath lab have a specific role. So we sat down and we discussed these things about what you're going to do, what the fellow's going to do, what the tech is going to do, and what the faculty member is going to do during the procedure, and then what you're going to do for bailouts in case there's a problem. I think it's really important to plan these procedures carefully and to do them. You do need to have success initially, especially if you're in an environment where there's skepticism, and there's always a skeptic in the cath lab somewhere that can find a way to criticize what you're doing. So we needed to be successful. So these were the roles that everybody played. I then let Justin decide at the end of the rotablator when he wanted to stay at the table. He wanted to go to the cockpit. So when the fellow goes to the cockpit, I go to the camera room and I just do some remote proctoring over a microphone so that they can all hear me. So Justin's there in the cockpit and he is doing the rest of the procedure robotically. We image now as much as we should, which is about 90% of our cases. This is something that has evolved in our lab over the last 5 years. We were, like everybody in the US, very slow adopters to imaging. I do a lot of imaging with the Volcano Philips IVUS system because it's compatible with the robot and because it is does not require pressurized contrast injections like OCT. When I do CTOs, I often use dissection and reentry techniques, and it's not very good to inject contrast down dissected vessels. So that's why I'm kind of stuck with this IVUS. That's Justin doing the IVUS. The other thing that's important is that you teach your technicians new techniques. They don't know how to shape wires in my lab. Some places do have their techs. So I had to teach Rachel and our other super users how to shape the wires. So she's making a wire shape because after we rotobladed the circumflex, we needed to robotically wire the LAD to protect it. So she is there shaping the wire. Some of the other things they need to do is advance the IVUS catheter. The Volcano Philips IVUS catheter can be used, but it cannot be used with the turbo mode. Turbo moves devices fastly through the guide, and it exerts a little more pressure, and it fractures both shockwave balloons and it fractures IVUS catheters. So those have to be, I have them deliver those manually all the way to the tip of the guide, and then do the ring down, and then manually advance and retract the IVUS. And now I retract IVUS with the constant speed pullback at 2 millimeters per second, which seems to be a very good pace for IVUS pullback. So those are things they've had to learn. The other thing they've had to learn is how to use guide extension catheters. They're able now and comfortable with advancing guide extension catheters down coronary arteries when there's a wire downstream to protect it. And that's something they all had to get used to. So this was Justin then robotically wiring the LAD. There's nothing terribly exciting about this. You've all seen people wiring, but one of the things I hear a lot of is, what about the lack of tactile feel? And I've been proctoring chronic total occlusions, 150 centers around the world between Finland and Australia over the last 10 years. And I'll tell you, I never touch the wire, but I can tell when the wires aren't in the right place and aren't doing the right things. And this is Justin using the buckling of the wire to know when he needs to pull back and redirect. And that I'm always comfortable with knuckled workhorse wires in large diseased vessels. And so it's just using visual cues rather than tactile cues, and you have to get used to that. I find that people who think that their fingers are magic believe a little bit too much in their feel and need to get used to using their eyes and their brains rather than using their fingers to feel their way through coronary arteries. I know that's anathema to interventional cardiology, but I think we all need to get over the tactile feel nonsense. You don't really need it. You can use visual cues. This is just an example of the guide catheter control and how really what a great iteration guide catheter control was to the GRX system. That's a guide catheter that's been moved. You can move the full 10 centimeters forward, 10 centimeters backwards, and you can spin the guide in perpetuity. The nice thing about the guide catheter control is also it tells you what arc you've spun the guide. So once you get to 360, you need to go back the other way so you don't twist the guide off, and that can be a good safety measure. But this is just rewiring after the guide had flipped out using guide catheter control, finished with a pot, and that was the final result on that case. We also believe in evaluating our practice. We think it's important to look at your practice, and I'm so pleased to hear that you have a registry there at Queen Elizabeth Hospital and that you are planning a more collaborative, larger registry across the Asia Pacific region. I think that's going to be fruitful and potentially powerful information. And it also, even if you just use it to provide yourself with your own feedback about how you're doing, how your cases are, how your volumes are going, and how your outcomes look, I think it's a great idea. So this was the hybrid approach. I'm not going to bore you with all the hybrid information in this presentation. I'll just tell you that the key takeaway from our analysis of our robotic PCI, CTO PCI practice was that you'll spend a lot of time in the cockpit. About 48% of the procedure time is spent in the cockpit if you cross CTOs manually and then hook up the robot and go sit in the cockpit. And we're talking about an average procedure time of 2 hours. An hour in the cockpit's a lot of time out of lead and away from radiation. And we've now have just completed a randomized trial between completely manual and robotically assisted hybrid CTO PCI at 3 centers, York, Pennsylvania with Bill Nicholson, Seattle with Bill Lombardi, and with us at Mid-America Heart Institute, and we're beginning the process of analyzing that data. So in summary, you can fit robotics into nearly every case somehow. You don't need to select simple cases except initially. The physician advantages are well established. The staff advantages do exist and have been published. Proving the benefits in patients has been the challenge, and I think will be less of a challenge as we move forward and develop remote and develop stroke interventions as well, where there's a huge unmet need. And then future developments, again, are going to be the key, but you're going to have to be involved in robotics now. We're not going to allow you to do your first robotic case 100 miles away from the patient. So in terms of other practice building advice, I'd say convince the hospital that, first of all, you're at risk. 30% of interventional cardiologists have back problems, and it can limit their career. You're worth keeping. In the United States, sorry about that. In the United States, interventional cardiologists are very valuable to their hospitals, and they are getting harder and harder to replace as the interventional community ages. You need to build a team, and I've given you some advice about how to select team members and what to look for. Master the device. Don't let anybody else tell you how to use the device. You need to be the one that tells everybody else around you how to use it. Practice, practice, practice. You have to think about, how can I use the robot in this case, rather than why shouldn't I use the robot? How can I get out of using the robot? You have to have a robotics first mentality. And then you should study your practice, and you should understand how the practice is growing and performing. And that's the best advice I can give about how to build a robotics program. So thanks very much for the invitation, and I really appreciate this opportunity to share some ideas with you about growing robotics programs.
Well, thank you very much, Aaron. Really a great talk. It's really good to share your experience, how you come all the way from the start of the robotic to now. You are using it almost every day. So we see if we get any questions.
There is a question from the floor about the training. So any certain syllabus of training or number of cases to be certified as a robotic operator? So what is the curriculum like?
Well, I can answer that. We still don't have actually a fixed number to certify operator, but for our program, our fellowship program, actually, we ask our fellow to go for the didactic lectures on the web. They have a lot of lectures, videos on the web, try to understand the system. And then we ask them to actually observe 2 to 3 cases, see us 2 cases, and then go to the bedside, try to connect the robotic arm for at least 3 cases. And then they will be proctored for at least 5 cases when they sit in the cockpit and do the robotic PCI cases. And then we will see his or her performance and certify him as a actually independent PCI operator. I don't think there is any fixed number yet, but that's our suggestion to become a fully trained fellow for now.
Okay, well, there is another question from Dr. Chen from Hong Kong, Katie Chen. So he's asking how many percentage of cases are you using robotic in your daily cases as default mode? So maybe Dr. Random, you could answer this.
Yeah, well, I would say that it's probably around 50 or 60% of cases. There was a time when I was higher than that, and I will tell you that you'll see ebbs and flows in your use. COVID has been a big challenge. We had a massive slowdown when COVID hit, and right before COVID, we hired 13 new techs and operators. So for a period of about 6 to 8 months, as we got new techs and new nurses in and trained, and we got through COVID, we had a big slowdown in robotic PCI, and we're now up to about the 50% range, I would say.
I think the other thing that we need to consider is the reimbursement policy, because for now in Hong Kong, we still don't have proper reimbursement policy. Patients have to pay out of their pocket if they want us to use robotic, and sometimes we have to explain to the patients whether we need to use robotic, what's the benefit. So it takes some time. And for us, the main hurdle now in our hospital is the reimbursement policy. So we are not doing robotics for every single patient, but we try our best to identify suitable patients for now.
Can you tell us how much extra cost would that be? Just roughly. We use the system.
For us, it's just 18,000 Hong Kong dollars more, because we have to provide a new cassette for the patient every single time. And then the system, we don't charge the patient for the system. So it's like 1 to 2 cents more for the patient if they have to pay out of their own pocket.
So Dr. Gwenson, this is Dr. Tam. So I enjoy your talk very much. So I just want to ask from my heart, from your experience, the very beginning while using the robot. So what is your major concern when you're using it? So is it the change of the tactile feeling to visual feeling, or other thing else you are really worried when you're early start of using the robot?
Yeah, I experienced the same concerns everybody else did about tactile feel, and I learned very soon that wasn't a real major challenge. For me, it was just separation from the patient. It was just like, I'm not standing there by the bedside. And it was almost a sense of guilt that I was doing this to help me. That, you know, this is for me right now. And I understood the vision and I wanted to be a part of the future, but I felt this sense of it just didn't seem right to be separated from the patient. But then I reflected back on how I teach fellows. You know, our fellows start in July and finish in June of each calendar year. And by January, I don't scrub. I sit back in the camera room and yell at them through a microphone and tell them what a bad job they're doing. And if there's a problem, I get up and I can get scrubbed in within, you know, a minute and be there to help. And so I overcame some of that that sense of guilt that I was being selfish.
How quick it can be, reverse back to traditional manual in case of emergency?
How frequently?
Yeah.
Yesterday I did. Go ahead.
Frequently,
yes, and also, yes, and how quick you can convert back to traditional.
Yeah. So look, yesterday I did 4 cases robotically. There were 3 straightforward angioplasties and 1 CTO. The CTO was in a 50-year-old with this unbelievably tortuous right coronary artery. Once we got through it, we were frankly terrified by how tortuous and calcified it was. And we were putting in 5.0 Megatron stents through a guide extension catheter that was delivered all the way down to the distal right coronary artery. And when it came to deploying the second stent through this really, S-shaped curve in the right, we just could not get enough pressure on the robot to deliver the stent. And I had to abort and manually use incredible pressure to re-deliver my guide extension catheter. So out of the 4 cases I did yesterday, 1 required a manual interruption after we had converted to robotics. And I would say that occurs, I don't know, 1 out of 20 cases maybe. And so they're, you know, and you won't really learn, I haven't really learned how to select cases to make that never happen. It's just going to be a rare reality in this. And the other thing we do, every time we disconnect the robot at the end of the case, I say something like, that's a wrap, or case ended. And the techs know they have to, as quickly as they can, they have to end the case, they have to disconnect the guide, and they have to take the robot and push it over to what I call the left radial position to have it out of the way while I scrub in, and we practice converting to manual emergently on every elective case. So they can do it in 10 seconds.
Oh, yes, very, very quickly. You just disconnect and then you can start manual. Yep. So it's just end the case, disconnect, start manual. So very, very quick.
In 3 out of 4 cases, we were under 10 seconds yesterday. So,
can I ask a question? So when we are delivering or removing gadgets from the system, sometimes we have to do 2 motions. I mean, we have to control the guide and we have to control the balloon or whatsoever. So is it possible to do the same thing with the robotic system simultaneously?
Absolutely. You can move the wire, the balloon. A common reason to do that is to sort of reseat your guide. If you've pushed a stent forward and you've kicked your guide out, or pushed a balloon forward and kicked your guide out, not infrequently, I'll blow the balloon up and I'll pull back on the balloon to seat the guide and advance the guide at the same time. So there's some movements that you have to control. And you can even, I take my thumb and my finger on the device and the wire, and my right hand on the guide catheter. Sorry, I can't show you on my camera. My right hand on the guide catheter control, and I can move the stent and the balloon and the wire in the same direction and the guide in the opposite direction simultaneously. So you'll get used to that. That's something that the gamers in the audience are going to laugh about. That's really kind of, level 1 gaming. So we'll see how they do when it comes to the next generation device, which is going to have more like a gaming control on it. And you're going to be able to do multiple things at one time.
Perfect.
So I am very sorry, but I'm going to depart from this great webinar. I hope you guys have a successful discussion and learn a lot, and look forward to.
Thank you very much. Thank you so much.
Thank you.
I apologize. Bye-bye.
No, we will invite you over to Asia sometime, face to face.
I'm waiting.
Yes. So
I hope so soon, guys. Bye-bye.
Bye-bye. Have a good day.
Bye-bye.
Have a good day.
So I guess we can proceed to the next speaker, right? So it gives me great pleasure to introduce the next speaker, my friend, Dr. Alan Carson Chan. Dr. Chan is currently the Associate Consultant and Director of Catheterization Laboratory in Queen Elizabeth Hospital, Hong Kong. He obtained the medical degree from the University of Hong Kong in 2002 and underwent a cardiac training in Queen Elizabeth Hospital. Subsequently, he received a Hong Kong Heart Foundation scholarship and underwent a 1-year training in advanced cardiac intervention in Case Medical Center, University Hospital, Cleveland, US in 2012. So he served as also a council member of Hong Kong Stand and board member of EPSIX. So he has special interest in TRIP, CTO, and intracoronary imaging, and performed various large cases in local and regional academic meetings. So he was an active promoter in primary PCI program in this region and served as the project manager of the Stand Save Alive in Hong Kong region. Of course, he is now interested in the robotic PCI. So tonight he will go to share with us some cases, and they have been done in Queen Elizabeth Hospital. Alan, please.
Oh, thank you, Dr. Tan, for the very kind introductions. You can all hear me, right?
Yes.
Yes. Okay. Thank you. So, by no means at the end of the symposium, it's already challenging. So the two great speakers have covers most of the essential elements. So, of course, at the end of the day, this is the last dessert. Hope you enjoy the symposium, and I'll go to show you some of the case and some maybe cover some part which haven't been touched by the two speakers. So, hold on. Wait, hold on. What happened? Okay. Can you see? Okay, so just a brief overview of the system. Probably haven't been touched. In fact, the robot actually comes with a what I call the arm together with what's called the consumable or disposable cassette. This is the consumable items that we are talking about. It costing about 18,000 Hong Kong dollars. This is the cassette, which we open up for each patient. So going into the cassette, actually, this is what is the robot working on. In fact, it's fairly simple manipulations and simple mechanics. It's not really fancy enough. Maybe in the future, they will have further next generation will be a bit more advanced functions. So in some ways, we can have what called the guide support track. This is attaching to the guiding catheters. And then the guide wire through the guide wire track. And there's also the rapid device track, which we advance our balloon and as well as the stand. Also, there's an auxiliary track, which you can able to park our wire or the balloon over there, just like when we are doing bifurcation lesions. So we need to use a very special wide connectors co-pilot. And we have also tried the others wide connector, which did not really fit into the cassette. So we need to have a special co-pilot wide connector attaching to a rotator here. Okay, so this is the console which the prime operator sitting on the chair looking at in front of the screen. So the magnification here, we can first of all, there's joystick controlling each of the items, including the guide wire, the guiding catheters, as well as the rapid exchange device. So we can advance and remove, retract the device. We can, apart from advance and retract the guide wire as well as the guidings, we can also rotate the guide wire as well as the guiding catheter. So we have, we can manipulate these three functions simultaneously or together. So apart from this rotation motion and advance and tracking, actually we can also advance or retract the device or guide wire or catheters millimeters by millimeters. And as well as we can measure the length of the DC segments as interest. Okay, so I don't know what happened. Okay, so this is what the exact setup I think Dr. Lee has shown you. This is our so-called cockpit, but it's not inside the cath lab. So we have the tables or with the TV screen. We have the console. Actually, we have all the other computers here. Actually, we can reply email. We can do our echo report. Again, we can see a console, etc. And so while the nurse and the tech inside are exchanging the gears. So this is the big screen. Actually, it's a high definition screen, up to 55 inch. You can see very clearly the procedure. And we can also see the hemodynamics, the accelerated imaging port, as well as the operators inside. So at the very beginning, we are all very eager to join in before we train up our nurse and dedicated nurse to be the one sitting behind the cassette. So in summary, actually, why is it the robotics is important important to us, or the high interest to us, is because there's several reasons. There's high percentage of procedure time in the past in wire manipulations, so-called the try and error, particularly when we are teaching fellows, and long hours and low procedures can result in increased contrast and radiations. So at the beginning and with the advanced technology, there's a built-up algorithm based on highly skilled operators, including those CT operators, which can standardize the procedure in order to improve the navigation, the lesion crossing, as well as the delivery of the therapies. And so much so that hopefully it may shorten the procedure, and at the end of the day, it will reduce the contrast radiation and to the physician, and also it brings of precision. So we hopefully have some positive impact to our patient outcomes. So this is some of the smart procedure automation which has been available only early this year. In the beginning, the only automation system is so-called the rotate on retract. This is ROR system, which is one of the commonly used smart procedure automations before the other available functions. So in fact, when we're talking about the wiring, there's no tactile feedback. So what you are going to perform is to visualize the wire positions and visualize the target, and then to rotate and then manipulate the joystick. So the R1 now actually can automatically retract your guide wire, and then when you advance again, you will rotate to a different direction to facilitate the guide wire advancement towards the stenotic segments, and to try to avoid going to the side branch. So newly added functions like wiggle and sprint is the more fancy function. I will go straight to one by one. So first of all, this is the hour now. So when you advance and then retract, automatically we will rotate the guide wire by itself. So it makes it more easy to negotiating lesions and vessels. So wiggle is a little bit fancy. You can see the controller actually spinning in the high speed, oscillating, try to advancing the guide wire through the tortuous segments. with the spinning is a more full motion of clockwise as well as counterclockwise mode. You can see it's trying to facilitate the advancement of the guide wire through the stenotic lesions, especially those very tight or subtotal lesion. You can see it once again. This is a more full clockwise and counterclockwise motion. Of course, at the end of the day, it's the combination of these automated maneuvers that able to try to negotiating the coronary segments. So I think all of you
Alan, you are muted, Alan.
Is there some technical problem? We can't hear Alan's talk.
Alan, you are muted. Hello, Alan. Can you hear us, Alan?
Sorry, Alan, we can't hear you.
I think he can't hear us. Alan.
喂，你 mute 咗啊？你 check 個 system 啦。Alan。
We cannot hear you.
Okay, sorry. Can you hear me now?
Okay, now we can hear you.
Okay.
Now we can hear you. Can you stop?
Okay, now?
Yes, we can hear you. Yes, okay, go ahead.
Can you hear me? Can you hear me?
Yes.
Okay.
Yes.
All right. So the current device cannot allow the compatible with a only allow rapid exchange system, but not over the wire device like microcatheters or other kinds of atherectomy device. So it's not fully compatible with some of the IVUS or OCT catheters and rotational or optical atherectomies. We have tried the IVL, it did work. So I will quickly show you some of the cases. So this is the most simple case I want to show you. This is the type A lesions of the circumflex. We treat the outside the culprit primary PCI in the first index settings and bring the patient back for a stage PCI. So we hook up the guiding catheters, the EBU to the robot, and then ride the circumflex robotically, of course, with the hour now functions at the beginning. This is one of the first few cases. We directly stand the mid circumflex while advancing the 3.0 DES and then post-dilate with the 3.5 balloon. And this is the final angiographic result. I think it's for type A lesion is very seen nowadays for most of our patients. So this is becoming more challenging. The 56 years old gentleman, effort anginas with distal outside bifurcation disease. You can see at the beginning, we don't think we're able to do it robotically. So you can see the distal outside, the bifurcations over the PL branch together with the PDA is kinds of reverse angle. I think for a standard PCI, traditional PCI approach, I think we may have a hard time to wire the PDA as well. So, but anyway, we tried the robot and then we first ride the PL branch first. And then we intentionally shape our wire in a reverse position and then pull back the wire by the robot. So we do it the first time, which I don't know whether it's advantage or disadvantage of the robot because it's really steady. Unlike your hands, we can rotate too much. Sometimes we'll miss the ostium. So for this particularly robotic alignment, you can see the first maneuver actually we entered the PDA, but somehow when we try to advance further, it get lost. So we did it again. So the second time again is not really, it's out of a surprise that it enters the PDA quite easily. And then when we further advance, we can able to advance the PDA without much manipulation by the robot. bear in mind, we don't have the new automated functions like the wiggle or spin while we're doing this case. So after ballooning and dilatation, we are going to stand across the PDA by means of modified gel balloon techniques in these lesions. So what Dr. Lee has shown you these pictures. This is what the stand going through the working port. This is the auxiliary port which our sideband balloon, the 1.5 balloon going through. And you can barely see these male connectors, which the nurse, the lab technician, is going to inflate the balloon here. So here is the 1.5 balloon going through the auxiliary port, and one is through the working port for the stand. After that, we have the post dilatations, and then further ballooning, and then this is the final angiographic result after the standard provisional standing by the modified gel balloon techniques. So subsequently, we have more confidence, and when you have interest, go to the robotic Corindus website about the robotic PCI. Actually, you can see some of our submitted case in the library, and this is one of the case that we did last year. So this is a LAD CTO. It's not really long. I think for usual operator, I think most of them can tackle it with much difficulties. But we try to use this as a case for the hybrid robotic assist PCI. Of course, this current generation do not really fit of a microcatheters, so we need to do it manually, manual wiring before we convert it to the robotic case. So first, we do it with a microcatheter supported XDA wiring. Initially, it's go into subminimal space, so we quickly set up to a guide first because it's a very short CTO, calcify a clear distal path. It's not much wire manipulation. We can able to come to the distal true lumen, and then this is what we able to exchange back to a workhorse wire. After wiring the diagonal, we then hook up our system to the robot. And this is what our nurse become very familiar. And for me, I think my job is done. And then I can able to sit down and complete the case with robot. So after ballooning and active lesion preparations to both LAD and diagonals, this is the angiographic result. And we think that we just plan to have the provisional standings, and again, we're using the same maneuvers, modified gel balloon techniques to treat this bifurcation, the 2.5 long 40s DES, gelling a 1.5 balloon, and this is the final angiographic result. I think all of you agreed this is the excellent end result. So becoming more challenging is these 60 gentlemen with F1 anginas, both RCA and LAD bifurcations. So RCA is the appetite, and the LAD is the main dish. So we do it again robotically. First of all, direct standing to the mid-right RCA using a 7 French IL-35 guides because we plan to do a complex bifurcation lesions to the left side. So followed by a NC balloon dilatation, and this is we can quickly achieve an excellent angiographic result. So sometimes manipulation by of the guide to engaging the coronary will be a little bit challenging. So we test this with the robot again, remove the guide from the right side and then crop the catheters and then try to engage the left side. So you can see for some case after a few cases we are able to achieve these kinds of guiding engagement by the robot. After that, with the wire park down robotically, we may I'm able to show you what clearly the left side look like. So you can see actually it's 011 bifurcation lesions with a big diagonal sidebands up to 3.0. So we planned for a DK crush stentings. So we first test it robotically in our lab. So this some of the very busy slides showing the sequence what try to facilitate the procedure. First of all, we use the robot to wire the diagonal and then park it in the auxiliary port. Secondly, we wire the LAD as well, and then we loaded the wire with the balloon, try to blow up the LAD lesion, and then to stand the mid LAD segments to complete the first part. After that, we exchange the LAD wire together with the 3.5 balloon to the auxiliary port, and then load the device to the D1 wire and then try to blow up the D1 and then followed by extending in the DK cross-extending fashions. After that, we can check the angiographic result before we pull out the D1 wire robotically, and then we try to plug it into the X-ray port. Subsequently, is crushing with the LED 3-5 balloon, and we pull the balloon, push the balloon down towards the mid LED for us to go to the wiring to the D1 robotically. So this is the real-time wiring by the robot. We confirm it's a very proximal stand truss, and then the wire actually through the robot go not very difficult, and then towards the distal diagonal segments. We open the D1 stand truss with the 2-5 balloon, and then do a sequential dilatation and then kissing. After confirming the result, we pull out the D1 wire and then stand the LED with a 3-5 balloon, 3-5 stand. Do a first port and then do a second rewiring again robotically through the stand truss. Not very difficult indeed. And advance the balloon to the D1, do the balloon dilatation, sequential dilatation, and then the final port. And this is the final angiographic result, all mostly done by the robot. Of course, we make use of the male connectors to facilitate the kissing throughout the procedure as in our daily bivocational standing practice. The last case, I think Dr. Lee has shown you briefly. This is the recent case which with the outside subtotal lesion. I think, again, this is very challenging lesions which at the beginning, we don't think we're able to do it robotically, but we may need to proceed to a hybrid approach. So after we set up the platform, we use a AL1 guide, 7 French, in order to give us more support. We use all the maneuvers to try to cross the lesion. Of course, the default ROR functions, and then we try to use the wiggle as well as spin to see how it goes. So in fact, you can see the wires goes bit by bit. And then once we cross the lesions, it's nothing very challenging. And after that, we use the doctoring function. I think this is the balloon, try to cross the very tight stenotic lesions within the doctor functions, which surprisingly is together, of course, with a very great support by the guiding. So we have not difficulty in crossing the lesion with the balloon. So after the pre-dilatation, actually, we can achieve TIMI free flow. And bear in mind, we need to stand all the way back to the proximal outside. So with these AL guides, even a manual PCI, when we are teaching our fellows, there's a lot of maneuvers, tricks and tips and tricks we need to tell our fellows how to manipulate. So, and in fact, this cohort what Dr. Granham and Dr. Lee have mentioned. So when we are doing manual PCI, there's a lot of two-hands coordinations, and as well as the manipulations, which we feel very comfortable and without really thinking what we are doing. But when we are using the robot, actually, we are trying to divide our maneuvers, manipulations from the two hands to step-by-step procedures. So first of all, we pass our long stand 48 by 38 DES to the proximal, the mid-right, mid to distal right. After that, we need to stand the proximal segments. And in manual PCI, we need to kick our guide eyes. How do we kick our guide eyes? We make use of the balloon. When we are inflating the balloon, we advance the inflated balloon so much so that there will be so-called action and reactions. The guiding will kick out from the ostium, and then we can pull the balloon. And then you can able to kick out the guide and stand the proximal segments. So this is the final angiographic result. And I hope you can appreciate this is the excellent angiographic result, and all done by robotically. So ladies and gentlemen, in order to conclude, robotic PCI can tackle most, if not all, simple cases. The newly added automated functions can enable treatments of very complex cases like bifurcation I showed you, the aortal osteo lesions, and also we have tried the shockwave lipocystry. And hybrid robotic PCI can enable CTO interventions as well, and reducing the on-table time and radio exposures. The future development of more device compatibilities or more stimulated wiring techniques by highly skilled operators may enable an even more wide spectrum of complex cases to be treated. So, of course, in the past, we all fancy the current technology. We never know that the technology will advance very quick. I think these pictures also highlight also shown by Dr. Lee, the first in human experience of tele-robotic stentings for a PCI in Indians, while the operators are doing in the PCI in the temples. So in fact, the technology advanced very much, and hopefully in the past, we may be able to have this fully automated hand functions, tele-robot in doing the very challenging procedures. So thank you very much.
So thank you, Adam. Very illustrative cases from simple to complex cases. Thank you. So maybe we can start the discussion, a more in-depth discussion on the robotic PCI. So let me start. Alan, I noticed that you need to, change the set from main console or main port to the accessory port. So nowadays, up to now, it still have only can advance one stand or one device by the console, not together, right? Alan, can you hear my question? Kelly, can you hear me? Maybe Michael, I guess you can hear my question. Maybe you can answer the question first.
Technical problem. Yes, for now, we can only move one device at a time. Yeah. I heard the advancement going on that allows 2 ports to be operated at the same time in the very near future. But for now, we can only move one device, either a balloon or stand at one time, and the other balloon or stand has to put on the auxiliary port. Oh, so we have to exchange manually if we want to do both for now.
I'm sorry, Dr. M, I think my computer's back to normal now.
Okay.
I don't know why my speakers or my mic have some malfunction. I'm sorry for the technical problems.
No problem. Michael has already answered the question. Yeah, I asked him whether we can move the device all together, 2 devices together, but for now it's only can move one device.
Hopefully we will have 2 ports. Yeah. Both can function very, very soon.
So I think according to the company, I think in the future.
Oh, we lost you again. I'd like to ask, maybe Michael can answer.
Yes.
So, our labs are always busy, okay? So of course, this is new technology and we are very eager to use it. So still, how much extra time do you think will be required for the use of this device? It's a balance of the work schedule and new technology, you know?
Right. I think there's a paper from Patel. He actually analyzed all his procedures and the extra time it will take. I think from his observation and from our experience, maybe 5 to 10 minutes more to set up the system if you are experienced enough. So it doesn't take really a long time, but when you balance between the benefits that you can gain for the operator, actually there are evidence from Patel's lab that there's decreased radiation to the patient as well. When you can actually raise the table very high, in which we cannot perform manual PCI, but if the table is very high, then the radiation to the patients actually are much reduced, according to his paper. And the extra time it will take is like 5 to 10 minutes.
I think this advantage is mainly get from the PCIs and in manipulating the devices. It can manipulate 1 millimeter from 1 millimeter. So manually, we can difficult hard time to have such a precise. But for robotic PCI, is more, I mean, very precise.
And then for measurement as well, because you can always advance the guide wire and then pull it back while you do this measurement by using your already opaque marker on the wire tip. So when you pull the wire out, you can actually measure what's the length of the lesion, what's the length of stent that you are going to use. But for now, as you know, we always sort of visual estimation. What's the length of the stent that we are going to use? And for this machine, you can measure it very accurately.
As you've discussed earlier on, maybe at the time being, it's a bit hard to convince our patient to use this because of the so-called extra 18,000 bucks of money. People might tend to think that, okay, this is a new device. The major benefit seems to be for the operators, but less radiation. I guess it takes a bit of time to let our patients digest this new concept. And also they could also actually benefit from the procedure by having, for example, less radiation and more accurate assessment of their lesion.
Yes, and there are some evidence showing that actually by using robotic PCI, you use less stents, although not very significantly. There are about like 10% less stent being used because you can measure it very accurately, and then you can place it very accurately. So unlike manual, when you like opened up a stent and you found that, oh, it's 2 mm, 3 mm shorter than I thought, you have to use an extra stent. So that's what's being published in the paper. There are like 8 to 10% stent that you can save for the patient.
That's
something that you can tell the patient.
That would be more appealing for the patient, right?
Right.
Now, just now, well, Dr. Grantham is not here, but he said instead of asking what we can do with the device, but we should be looking at what we can do with the device. So I think this is a very positive approach.
Yes.
But I still like to ask, so maybe Alan or Michael can tell us what exactly you cannot do with the system.
Or maybe Alan, you
feel is more challenging when you want to use
the current
this.
generations do not allow the over-the-wire the technology. That means the whole loss of, for example, microcapitals, the real CTO wirings, even the, for example, retrograde septal serving, you cannot really able to do it robotically. So I think the company is working on the over-the-wire system. So once it's available, I think it's a major step forward. Apart from the currently newly available automated functions to wiggle the spin. And also they are also incorporating the master skill operators like those CTO operators, including Dr. Grantham. They try to stimulate the wiring techniques. And then the joke is one fine day you may be able to press the button and then you'll be able to get the Grantham's skills. You're able to get the OGI skills or your own techniques. You can. No one knows what will the future, but probably they're working on that. I've seen some pictures showing the labs. They're trying to stimulating those core master skills. So it's not a mystery at all in the future. In every lab, and you press the button, you may be able to get, just like you are playing video games, you have all the skills, all right? And then you can see how it goes. I think it's also worked for example, the retrograde intervention septal, the retrograde, particularly, for example, the septal channel crossing. I think most of the time, I think robotically may be able to tackle for the real difficulties, and it will become more generalized approach for everyone. No longer be a mystery.
So for now,
secondly, I think
almost all the imagings are not compatible except Volcano IFAS. So all the other IFAS, OCT, OFDR are not compatible with the system. You have to do it manually. And all the atherectomy devices, except IVL, rotablator, orbital atherectomy, they are not compatible with the system. So these are the concerns when we plan to use these devices, that we might actually either consider hybrid technique or actually not using this robotic technique for these few selected cases.
Right. Just now,
there's a second advantage.
I guess, well, it's well known that for CTO intervention, there would be more radiation, more procedure time. So in the future, if this is really possible, then it really helps to save the radiation.
Yeah, it's actually there's another advantage for, I think it's not really in the current setting. It's so-called the telestentings. So this is one of the key future probably for the robotics. For example, in those overseas countries, in those rural areas which they cannot access to really a PCI. That may be a solution for part of the rural areas. So I mean, in those not with the come with the operators. So they may not have the skilled operators. So that's why telestenting may become a possibility. Either the less well-developed countries, or even in primary PCI setting. No one knows what will be the future. I think the first world case by the Dr. Patel showing the telestentings for mouse is a landmark for.
I guess what we're looking at in the future, whether we can shorten our door-to-balloon time even further with this robotic technique when we have to do a PCI, primary PCI in the middle of the night. Whether you can in your table, stay in your house and then start a primary PCI procedure with a fellow and a nurse in the lab. Hopefully, that's the future.
Yes, I guess with 5G technology, you'll be more workable.
Yes. And now the robotics actually extend to neural intervention as well as peripheral intervention. A lot of work has been going on, and also hopefully in the future it will include structural heart interventions as well. Because when you do a TAVI procedure, the stability of the valve is very important. I'm sure with this robotic technique, you can actually place the valve very stably inside the aortic annulus instead of using a sort of a manual like what we are doing now. So I think that might be the future. A lot of development is anticipated in this area.
So I guess it's prime time that we all start to learn robotic PCI then, in order to survive in the field.
Go for the test drive tomorrow. I think they book a whole day of test drive sessions. If you are free, go to the, I think it's the Marco Polo Hotel, and you can actually really feel how does it feel when you do a robotic PCI procedure on a model.
Okay,
nice.
All right, I guess it should be almost time that we should close the session. Before we close, maybe I can invite Michael to deliver a closing remark for all of us.
Well, thank you very much, CK and Leiwa, for sharing this session. I think this is the first, hopefully it's not the last, robotic PCI webinar in Hong Kong. I know a lot of our Asian colleagues have joined us, and we really hope we can learn this technology together. It's going to be very helpful both for the operator, because you reduce your back strain, reduce the occupational hazard, and also reduce the radiation. But at the same time, actually, it helps the whole procedure to be more precise and help our patients receive less radiation. So in the very near future, we hope we can collaborate with more robotic operators to advance this technique, to advance this technology, and very hopefully in the very near future, we will have this 5G capability so that we can do this tele-robotic stenting, PCI procedures very soon. So hopefully we can have this sort of interactive webinar or even face-to-face meeting on this particular robotic PCI technology very soon. So thank you very much for your attendance.
Thank you.
Thank you.
Thank you, and have a good night and good day. Keep safe and keep healthy.
Bye-bye.
Bye-bye.
Bye-bye.